Good evening and welcome to our webinar, SpaceOar Gel for Prostate Radiation Treatment, presented by Dr. Jeff Skinner. Dr. Skinner is a radiation oncologist who earned his medical degree from the University of Virginia School of Medicine and completed his oncology residency at Montefiore Medical Center, Albert Einstein College of Medicine in New York City. He is a graduate of the United States Air Force Academy, and he served 20 years as a military physician, including a deployment in Iraq. Dr. Skinner joined Chesapeake Urology in 2019 and sees patients at the Prostate Center in Gaithersburg. Welcome, Dr. Skinner.
Good evening. Good evening. So tonight the objective is to talk a little bit about prostate cancer treatment options and, from my perspective as a radiation oncologist, and try to give some thoughts on the idea between optimizing cure and also thinking about quality of life and how those two are very related, and improvements and things we can do and to make a difference in both getting cure and having a good quality of life are very important to us. So we're going to talk a little bit about the anatomy of the prostate, a little bit about prostate cancer and its common, how we get the diagnosis and treatment options, and then going to discuss in the end one of the technologies that we're using to optimize cure and to limit the side effects and some of the things that are both bothersome and can significantly affect quality of life, and how radiation's evolving, to be able to make that difference to treat cancer and to maintain a level of quality of life that's important to patients. The prostate is located underneath where the bladder is, and it's in close proximity to both the rectum, the bladder, and then the urethra goes directly through the prostate. And one of the advantages or one of the differences between surgery and radiation is that with radiation, we leave the prostate in there and we treat the prostate in the body. And so we maintain the urethra, we maintain the structures, but we have some important structures that are surrounding it, the bladder, the rectum, and the urethra, that are responsible for some of the side effects that we see. So it's a trade-off between treating the prostate, getting rid of the cancer, ensuring that there's a quality of life and limitations of side effects. Now, prostate cancer to some degree is a cancer of aging, and if you live long enough, there's a good chance that you will be diagnosed with prostate cancer during your lifetime. There's certain risk factors, special care, and even though there's been some changes in the screening guidelines, there are some men that we want to make sure that we're screening early. I think the good news is that there's much more of a spectrum of watching prostate cancer and only treating when it's potentially clinically significant, and using MRIs and using molecular risk scores to try to make a better determination of whether this prostate cancer is going to be clinically significant. Like I tell my patients, that having prostate cancer that's in your prostate isn't really something that I worry about. What I worry about is prostate cancer that can either grow aggressively when the prostate causing symptoms, and prostate cancer that can spread to the lymph nodes, the bones, and other organs. That's what we're trying to target. So the numbers are large. And I think there's kind of two big take-homes from this. And one, they're large. If you live long enough, you're going to have a chance of getting it. But the deaths are small compared to the number of new cases. The time course is long. And oftentimes when I'm seeing patients, I tell them they're not going anywhere anytime soon, no matter what happens. And you can look at the 5 and 10 year kind of survival rate, and it's high. The deaths are high as well, but that's because there's so many patients that are diagnosed. And typically with the time frame that I try to let my patients know is, a lot of times when I'm treating you, it's an insurance policy. It's an insurance policy when you have 20, 25 years left to live, that your prostate cancer isn't going to be a reason that you're going to die, that you're not going to have metastatic disease 10, 15 years down the road. But, prostate cancer, for the most part, is a disease that can be treated with good survival. And there's a lot of room for kind of hope and optimism. Now, how do we diagnose prostate cancer? We touched a little bit on the screening, and that's a little more complex of a subject today, but certainly screening does have a role, and a screening with high risk features has a role. There's two ways that you'll be diagnosed with prostate cancer. One is you're participating in some level of screening, and you're getting a PSA and you're getting a rectal exam, and there's some abnormality. some rise in the PSA, something that would get you from your primary care doctor to a urologist, potentially an evaluation to see what the risk would be of prostate cancer, leading to a prostate biopsy. Other reasons that you would get detected is if you're having trouble urinating, if you're having any type of symptoms, bleeding, and during that process, a PSA is checked or an abnormality is found, and then you'd have a biopsy at that time. Different ways to get the biopsies, and oftentimes this is a little bit anxiety provoking to think about getting the biopsy and getting the tissues. And this is the first step, after the suspicion is raised, to get the diagnosis. Biopsies, two main flavors of biopsy. And one of them is kind of a traditional 12-core systematic biopsy that takes different samples from different areas of the prostate. We're starting to now get sophisticated MRIs, which is a specialized imaging study that can show some more details of the prostate. And that may be a part of some of the diagnostic workup for prostate cancer, both for diagnosis and for trying to determine the stage to impact the prognosis. So Gleason score, once we get a biopsy, we look at that under the microscope, and a pathologist is looking to see how well behaved the cells are. The Gleason score of 3 is kind of the lowest of a reading that you can get. And we get 2 scores. We get a primary and we get a secondary. And this is just based upon the predominance of these cells within the prostate. So a Gleason score of 6, 3 plus 3, is a low risk disease. May or may not have the ability to even spread. And we don't grade below that, or at least we don't call that a cancer anymore. We used to grade below that. A Gleason score of 5 plus 5, 10, is a very high risk, a very aggressive type of cancer, which is going to have different behaviors than the low risk disease. So looking at that under the microscope is where we start with this grade group to try to give an idea of what the prognosis will be. The next is the T stage, what we can feel on exam, and the imaging, discuss the MRI as a potential, although we don't always get that. And then CT scans, MRIs, bone scans to look at disease in the pelvis, lymph nodes in the pelvis, and bones to see if the disease has spread. The PSA test is oftentimes the first entry into this, a screening profile. But in a non-screened group, we also look at the PSA. And although the PSA is not perfect for giving us indication of risk, higher typically has a indication for a worse prognosis than a lower test. There's some other factors when looking at the PSA. How fast the PSA is going, how fast the PSA has gone when we compare it to several years ago. That's the PSA doubling time. And so there's some other indications on the PSA that may have some indication on the prognosis or how aggressive the cancer may be. Genomic testing, molecular testing, these are new tests that we're doing to look at how rapidly the cells cycle, other genes and products that indicate that it may have the chance to spread. It has a metastatic risk. So we're using those to make decisions both upon whether we can watch active surveillance, safely watch the disease. If it's going to remain indolent, and my saying, if it's in the prostate, I don't really care. If it's going to stay in the prostate, then we can watch it. We can watch it safely and avoid any type of treatment side effects. And I always want my patients to have confidence that when we make that decision that they don't have to worry about it, because we don't want you worrying about disease being aggressive if there's things we can do to minimize that. And also to give us an indication that maybe this is a little more aggressive and we need to potentially combine more treatments. Volume of tumor, some of the imaging can give us an idea of that and where it is, whether it's pushing outside, whether it's involving the seminal vesicles. There's a combination of some of these risk assessment models that can give us an idea of the prognosis. Treatment options. The way I try to look at this with my patients is I kind of imagine a road that we're walking on when we get a diagnosis of prostate cancer. And I like to take it in a very systematic way. So the first place we stop is the question of, do we need to treat or not? And this is really a question of active surveillance or not. But that's the first question of, do we need to treat? What's the patient's risk management kind of tolerance? And what is the prognosis that we think? Do we think this is very low risk? Is this low risk? Is this favorable intermediate risk with a favorable molecular risk or genomic score? Or is this kind of low risk Gleason score and it has a more unfavorable molecular genomic score? Is there anything on the MRI that concerns us? And we kind of add this all together and try to come up with the decision of whether we can watch this or not. And sometimes this is starting a long-term process of active surveillance, and sometimes it just potentially safely allowing us to delay to get data at another time point to feel more comfortable with whatever decision we would make. Surgery does have a number of benefits and downsides to it, and there's different ways to do the surgery, but the surgery with the robot-assisted laparoscopic has a very good risk profile, and it's a good option. And kind of when I tell my patients, because this is the next stop, once we decide to treat, the next question is surgery, yes or no. I tell them that surgery has a little more certainty than radiation. Surgery, your worst day is going to be the day after surgery. You're going to be in the hospital. You'll have whatever happened after the surgery. You'll have a catheter in. You'll be incontinent, and you'll be impotent. And then you get better from there. Most of the time, you get a lot better from there. You also have the pathology that you can look at to look for whether there's risk factors. Some of those risk factors will increase the chances that you may need radiation therapy either after the surgery or at some point in the future, but it allows us to monitor. And then we can get a PSA, and that PSA should be undetectable. That can give some certainty. But just because it's undetectable right after surgery, whether you get radiation or surgery, prostate cancer is something that we follow for a long term. You can't have recurrences that occur years after treatment. First step is treat or not treat. Second step is surgery, kind of yes or no. When you're in my office, whether you have decided or not, we'll have to go past that decision so we can get to radiation therapy. And when I get to radiation therapy, I kind of explain how I view the prognosis, and I'll take your pathology and break it down, and I'll tell you what I'm certain about and what I'm uncertain about, and kind of honestly give you a risk profile. And when I'm doing that, I'm really looking at how many treatments that I need to do in order to give you the best cure, matching that to your quality of life. If you're 75 years old, quality of life and cure looks a little different than if you're 52 years old. And so we kind of accommodate that. We also look at quality of life issues you have it going in, urinary function, sexual function, how are your bowel movements. So we really get into the details of trying to understand what your quality of life issues are now and how you view that. Understanding that, we start looking at the prognosis, again, talking about the very low, for the most part, being ones that we're going to talk about active surveillance as a real option, moving into favorable intermediate risk disease, in which active surveillance still may have a role. Low and favorable intermediate risk, we start looking at whether we're going to add a genomic score or not, molecular risk score, to get a little more information about what the chances are that this may spread. And low risk, favorable intermediate risk, we're looking at one treatment, whether it's external beam alone or brachytherapy alone, as being a potential singular treatment that can solve the issue of cure and minimizing side effects. Once we get into unfavorable and kind of low volume, high risk disease, we'll go through the pathology, and it can be a little complicated when we talk about the number of cores, the PSA value, and the Gleason score, and throw in some of the imaging. It gets a little complicated, but we'll go through that and make sure you understand that, because that's important. But typically when we get into unfavorable intermediate risk and low volume, high risk disease, we start talking about adding two treatments: androgen deprivation, hormonal therapy, which is where we use hormones to cut off the fuel for prostate cancer and also make radiation work better, but with some side effects. Side effects being fatigue, hot flashes, and then an impact on a number of endocrine-related quality of life issues: libido, sexual drive, erections, bone health, cardiovascular health, metabolic syndrome, and some emotional components to it. So we really kind of take that seriously as well, talk about how to add those together. Some patients were able to, to talk about adding external beam with brachytherapy boost. Details of those treatments and how we do them are a little bit complicated, but the overall idea is you've got outside and inside radiation with a little bit different side effects. And we kind of mix and match those based on your risk group to maximize the cure. Now, for very high-risk disease or high-volume, high-risk disease, these are typically ones, if we're doing radiation, we're wanting to add all three. Long-term androgen deprivation, hormonal therapy, block that fuel source for a long period of time before radiation, give a little bit of radiation from the outside, and then bring a high dose of radiation with the brachytherapy in order to maximize our chances of cures. This has the most side effects associated with it, but also the most significant disease that we need to impact, because this is the disease that, unlike the ones where 5-10 years we think you're going to be around, and radiation is more of an insurance policy to maintain that, there are some lethal prostate cancers that we need to treat very aggressively, and we take a little bit more impact on some short-term quality of life. And this is where we're talking about kind of the bowel, urinary, and sexual side effects and different ways that we can kind of alter and improve that. So this is a picture of what outside radiation would look like. And the way we do this is we have you come in for a CT simulation, and we're going to want you to have an empty rectum and a comfortably full bladder. And to do that, we'll have you urinate when you get here. We'll give you a set amount of water to drink, and we'll time about 45 minutes, an hour, while we're going through the process and the consent and getting you ready for our simulation. Then we do a simulation on a flat table. We'd have your legs in some type of immobilization so we can repeat that. We put 3 marks on you so that we can line you up when you come back, and we'd start treatment about a week or 2 after that. There's differing time frames that we can do the treatment, up to 9 weeks, shorter into 6 weeks. A shorter treatment that we can do in 5 weeks, and I typically do the 5-day treatment over a 3-week period of time. Now, for the 5 treatments, I typically add a spacer, which we're going to talk about, and we'll talk about the reasons why as we go into some of these side effects. And we use a rectal balloon, which eliminates the motion of the prostate, allows me to be a lot more accurate. And sometimes we'll get an MRI so that we can see exactly where some of the critical structures of the prostate are. So what's radiation obviously can solve problems, and can solve problems in a relatively simple manner compared to surgery. But there is a downside to this. Now, radiation, it's interesting in how radiation works that the first time people have an external beam radiation, they don't feel anything. They don't see anything. They don't smell anything. And the radiation is just like getting an X-ray. It's just high energy X-ray that we focus directly on the prostate. We use image guidance. So we line up our target area every time. And then we have intensity modulation, which means that the beams are shaped to treat the prostate while minimizing the dose to the bladder, rectum, and urethra. But even with that, we have to add a margin. We have to account for some motion. It's not perfect. And so these are where some of these side effects come from. The main side effects are urinary bother symptoms, and then the impact of having bowel dysfunction, rectal bleeding primarily, and some changes in the stools and some residual urgency. Very careful to make sure that we don't carry the radiation, the high dose radiation, down into the anal sphincter area. That can be associated with rectal leakage, especially as men get older, and there's a natural potential for some changes that can increase rectal leakage, and we want to be very careful about that. On the left side, some other ways, proton therapy, and a lot of people have heard a lot about proton therapy, and what I tell my patients is it's not going to make the treatment more effective. And some of these, the same kind of collateral damage will occur with protons as it does with photons. There is less integral dose or less dose that some parts of the body will see with proton therapy. The potential advantage in secondary malignancy. There is an increase in bladder cancer and rectal cancers that occurs with radiation. Typically, these cancers are 15, 20 years down the road. It's very low, a very low risk of these, but proton therapy does limit the integral dose. The stereotactic CyberKnife, that's the 5 treatments that we do. The image-guided, either imaging for the prostate and the rectal interface, or with markers, fiducials that we put in there. The intensity modulated radiation component. And the 3D really is, if you hear people talk about radiation from 15, 20 years ago, this is an older radiation. It was to a lower dose than we do now and had a lot more kind of collateral damage. Brachytherapy, there's a couple different ways you can do this. I do low dose rate, and what this is iodine 125 that we implant into the prostate, rice grains that we put directly under ultrasound visualization, similar to how the biopsy was done, but instead of going through the rectum, we go through the skin between the scrotum and the anus under direct ultrasound visualization and put the seeds in there. We do it both as monotherapy for kind of low and favorable intermediate risk. For some select unfavorable, if you have a Gleason score 4+3, we'll do that. And for combination therapy for especially the very high risk and high risk patients that will boost to our external beam treatment in order to get it as close to an ablative dose that we can. Trade-offs with brachytherapy are more urinary side effects. Bother symptoms, frequency, urgency, hesitancy. If you've got obstructive symptoms going in, this is going to make it worse and lasts about 8 months. Peaks about 2 weeks after the treatment and about 2 months, and we have a slow decline. We have to work through that. HDR, I don't do HDR, but that's using temporary implants. And as a boost, typically there's two separate implants that are used. And the advantage of this is potentially less urinary bother side effects with high dose rate implants. And some salvage procedures, difficulty in doing surgery, removing the prostate after radiation. If you do have a local recurrence, there are ways we can do brachytherapy both with LDR and HDR to give local recurrence additional treatment. So looking here, so this is giving you kind of what we call a dose cloud. And on the left, you can see this is kind of cutting you like a bread slice there. The other one's cutting you in half, kind of midline. And that's the prostate. You can see some of the markers there. You can see the rectum that, maybe if I had my pick, it'd be a little more empty. So I'd probably start you on Metamucil. Hopefully I would have started that earlier, Metamucil, and try to get you a little more regular to get that school out of the way, but that looks fine. But you can see that dose cloud that's including a fair amount of the rectum. And then when you look on that kind of cutting the middle, you can see that there's a fair amount of the bladder that's in there. And that's a decent, comfortable filling of the bladder. So I would be happy with that. And every day I'm looking at this, and my patients will tell you, I try to regiment you and get you disciplined so that we can have things repeatable. You can see the penile bulb. So that's the base of the penis, and kind of the importance for that is while we're not 100% sure of all the factors of what we can do to improve erections, the penile bulb is where the kind of the plumbing part goes into maintaining erections. And we want to keep that dose as low as we can. And in the middle of the prostate is the urethra. And with that, we want to avoid hot spots on that area. So this is giving you an idea of kind of some of the collateral damage that we get from external beam, SBRT type of situations. And so now we're looking at what can we do to minimize this. And this is looking at SBRT, which is CyberKnife, and something that we did. We had 2 cases tonight that went beautifully. And they both had a spacer and a rectal balloon, and they're really good plans that I'm very pleased with. But this is looking at late toxicities, and this is adding all of them up. Some of these toxicities maybe don't matter as much, but some of them do matter. And let's talk about the gastrointestinal symptoms that matter. Bleeding matters, and the ability to space out the rectum to essentially make bleeding that it has a quality of life effect almost non-existent. It really is a very comforting component of giving radiation. We've gotten a lot better, but it used to be these rectal bleeding and ulcers were something we really worried about with radiation. It really is amazing that we're able to give as high doses and even escalate that and be able to use this spacer to essentially make that non-existent. Genital urinary kind of bother symptoms, frequency, urgency. This is also adding in some of the more worrisome ones, which are patients that end up with kind of chronic bladder issues with frequency every hour, every 2 hours, not able to hold their urine very well. Strictures, tightening of the urethra, which again are things that we don't want long term. Now, for all of my treatments, I know there's going to be some irritative component during my treatment. The bladder's right there, the urethra's there, the prostate there. I'm causing irritation. And I would say 75% of patients will have bother symptoms, and how significant it is sometimes depends upon where they start from. There's some medicines we can give to make it better. But the genital urinary, having that spacer there, making it easier to get that rectal dose also makes it easier for us to kind of stay off some of the bladder, stay off some of the external urethra near on top of the penile bulb, and also try to manage some of the dose to the central area where the urethra is. And I'd say this data is pretty consistent. I do not see any of this worrisome gastrointestinal at all in my patients. So here's what this technology is doing, separating out the rectum and the prostate. It's also able to dampen some of the prostate movement when the rectum moves, and that's another advantage. When I add the rectal balloon, which is able to stabilize it even more, I'm seeing 1-2 millimeters of movement during treatment, which really enables me to accurately define things and decrease my margins that I'm adding for any movement, which helps patient outcomes both for cure and for quality of life. This is trying to give you a schematic of prostate and the dose that's surrounding it. Obviously, we prefer not to give it, and adding the spacer is helpful. Now, how do we do this? We do it similar to the brachytherapy. It's a needle that goes in between the space that exists, put some saline in there to open it up, and then it's a gel that goes into that space, solidifies in that area, and then it's dissolved in the body over a course of 6 months or so. Now, there are some potential unpleasantness, and right after procedure, you can have a little bit of discomfort and a little bit of rectal urgency that seems to last only for 5-6 days after the procedure. So I don't know if anyone has ever done a bowel prep, but that's kind of some of the things that are in the bowel prep that you use, and it's dissolved into the body, brief procedure, and spaces it out and allows us to do a better job with radiation. So this is kind of the whole view that we have. More space allows us to feel more comfortable with our rectal complications. And by opening that space up, we're able to manage the dose to the rest of the prostate in a better way. And so we're doing more and more of this.
Thank you, Dr. Skinner. For more information or to make an appointment, please visit us at ChesapeakeUrology.com, where self-scheduling for appointments is now available. Dr. Skinner is available for in-person and telehealth appointments. Thank you very much for joining us, and have a great evening.